Hello everyone, I'm Dr. Divya Tessa and welcome back to ACE Anatomy, where anatomy becomes simple, visual and unforgettable. Anatomy becomes truly meaningful when you can apply it in clinical practice. In today's Anatomy in Practice episode, we will learn how to identify and localize radial nerve injuries using clinical signs, muscle weakness, sensory loss and common mechanisms of injury. Let's bridge the gap between anatomy and clinical medicine. Before we begin, let's look briefly at the course and the distribution of the radial nerve. So the radial nerve is the largest nerve of the upper limb and largest branch of brachial plexus, and it has the root value of C5, C6, C7, C8 and T1. And in its distribution, it supplies all the extensor muscles of the arm as well as the forearm, and also supplies the brachioradialis, the brachialis as well as the supinator muscle. The radial nerve also gives sensory supply over the posterior aspect of the arm as well as the forearm, including the lateral aspect of the lower part of the arm as well as the lateral part of the dorsum of the hand as well as the lateral 3.5 digits, except for the nail beds. Let's now look at the sites of radial nerve injuries. So the radial nerve may be injured at three sites: in the axilla, in the spiral groove, and at the elbow. Radial nerve injury results in both sensory loss as well as motor loss. The sensory loss is mainly seen on the posterior surface of the arm, the lower lateral part of the arm, the posterior surface of forearm and the dorsum of the hand, as well as the lateral 3.5 digits except for the nail beds. The motor loss we see is the loss of extension and the loss of supination in extended elbow. These sensory and motor loss depends upon the site of the radial nerve injury. The first possible site of radial nerve injury is the axilla, classically from crutch pressure or a dislocated shoulder. Because the injury is higher before any branches are given off, the patient loses everything the radial nerve supplies. Let's look at the characteristic clinical features we see in crutch palsy. Since there is motor loss, we see loss of extension of the elbow due to paralysis of triceps. There is loss of extension of wrist due to paralysis of wrist extensors, and this causes wrist drop due to unopposed action of flexor muscles of the forearm. There is loss of extension of the digits due to paralysis of extensor digitorum, extensor indicis, extensor digiti minimi and extensor pollicis longus. There is loss of supination in extended elbow because the supinator and brachioradialis are paralyzed. Here you need to remember that supination is possible in flexed elbow by the action of biceps brachii. In addition to the motor loss, there is also sensory loss. The sensory loss is seen over the cutaneous distribution of the radial nerve. So we see the sensory loss over the posterior aspect of the arm, the lower lateral part of the arm, the posterior aspect of the forearm, as well as the lateral part of the dorsum of the hand, including the lateral 3.5 digits except for the nail beds. Injury at the radial groove is the injury you will see most often in exams and real practice. A fracture of the shaft of humerus, a faulty IM injection right at the spiral groove. Remember, that's exactly where the nerve winds around the humerus bone. This is also called Saturday night palsy from someone falling asleep with the arms hanging over a chair compressing the nerve for hours. Injury to radial nerve occurs most commonly in the distal part of the groove beyond the origin of nerve to triceps and the cutaneous nerves. So the clinical features seen here are weakness of extension at the elbow because the long hand, the medial head of triceps are supplied before the radial nerve enters the spiral groove. Then we have loss of extension at the wrist, loss of extension at the digits. There is loss of supination in extended elbow, and the sensory loss here is restricted only to a small area over the dorsum of the hand between the first and second metacarpals, because again the cutaneous nerves are given before the common site of injury or injury in the spiral groove. Now let's actually understand wrist drop. Every muscle that extends the wrist and fingers is supplied by the radial nerve. So when they are paralyzed, the flexors, which are supplied by median and ulnar nerves, are completely unaffected, have nothing to balance them. So the wrist falls into flexion unopposed. It's not that the wrist is stuck, it's that one whole team stopped playing while the other team is still fully active. That imbalance and not weakness alone is what produces the deformity. The site of injury is at the elbow, where the deep branch, the posterior interosseous nerve, passes through the supinator muscle. This can be compressed here sometimes from a radial head fracture or from repetitive forearm. The compression of the radial nerve at the elbow may also be caused by fibrous bands which can tether the radial nerve to the radiohumeral joint. Then sharp tendinous margin of extensor carpi radialis brevis can also compress the radial nerve at the elbow. Then a leash of vessels from the radial recurrent artery can also lead to compression of radial nerve. The radial nerve can also be compressed by the arcade of Rosset, which is a fibroaponeurotic proximal edge of the superficial part of supinator muscle. The radial nerve compression results in what we call as radial tunnel syndrome. So it's an entrapment neuropathy of the deep branch of radial nerve at the elbow. So here the characteristic features are pain over the extensor aspect of the forearm. There is loss of extension at the wrist. There is loss of extension at the digits. But remember, there is no wrist drop. This is mainly because the brachioradialis and the extensor carpi radialis longus. Both of these muscles are supplied directly by the radial nerve before it terminates into its deep and superficial branch. So how to test the radial nerve clinically and point towards the site of injury? You ask the patient to extend the wrist against resistance and check sensation over the dorsal first web space. If both are affected, it points towards the spiral groove lesion. But if only motor loss and there is normal sensation, it points towards the posterior interosseous nerve. Now this is examination gold. So one clinical sign, two possible sites, and now you know how to tell them apart. And to summarize, the radial nerve injury can occur at three sites: the axilla, the radial groove, and at the elbow. In the axilla, we call it as crutch palsy and wrist drop. At radial groove, it results in two clinical conditions, that is Saturday night paralysis as well as wrist drop. In the elbow, we call it as the radial tunnel syndrome or entrapment neuropathy. And that brings us to the end of today's episode of Anatomy in Practice. I hope this video has helped you understand not only the different injuries of radial nerve, but also the anatomical basis behind each clinical presentation. Remember, the key to mastering clinical anatomy isn't about memorizing the symptoms, it's understanding why they occur. When you understand the anatomy, diagnosis becomes logical and clinical reasoning becomes second nature. If you found this video helpful, give it a thumbs up and share with your friends. Subscribe to Ace Anatomy for more videos that make anatomy simple, visual, and clinically relevant. Don't forget to click the notification bell so you never miss an update. I would also love to hear from you. So if you have any questions or suggestions for future Anatomy in Practice episodes, leave them in the comments below. Thank you so much for watching. I'm Dr. Divya Dasa, and until next time, keep learning, keep thinking clinically, and keep acing your anatomy.